I will talk about the arthroscopic anatomy of the hip joint. And that was backwards, was it? Okay. We have heard about the arthroscopic technique. I will not go into that. Just mention that my talk will concentrate on the central and the peripheral compartment. I will not talk about the lateral or external compartment. This is the classic arthroscopic anatomy of the hip joint itself. When you enter into the joint, as Vikas described, it's the same procedure. Either you go from in a lateral position or lateral decubitus or in a supine position. And your first vision will always be the acetabulum and the acetabulum labrum and the femoral head. Like we see up here, is you see the femoral head, you see the acetabular wall and the labrum. And that's very important that you have this picture, because that will lead you to how to introduce your second portal, which you do under direct vision when you enter into the central compartment. As described by Vikas, the central compartment is limited by the extension of the labrum, and you can enter into the central compartment from all the portals described by Vikas, except for the specifically designed peripheral compartment portal described by Dinst. This is a short video that shows you have entered into the joint, and this is the triangle where you want to enter your second portal. So this is very important that you have this vision before you enter into the joint. Then you can see that you will not harm the labrum with your needle placement. The labrum is up here. So if you don't have this picture after you have introduced the scope, I would recommend you to reintroduce your scope until you have this picture and then move on. When you're in the central compartment, you have a little bit different views if you look at it from the anterolateral portal or the anterior portal or the anterodistal portal, as we often use when we are in the supine position. You can always have a better look down into the posterior part of the acetabulum and the ligamentum teres when you look from the straight anterior portal, which have the scope is directed more down into the joint, and you have a better vision of the lower parts of the joint, which is the area which is most difficult to access. Looking here from the anterior portal down into the joint, this is what kind of picture you will see. Here is the femoral head, here is the ligamentum teres, here is the cotyloid fossa, here is the labrum that's surrounding. Most of us will use mainly the 70-degree scope for the hip scope, and that takes a little bit of experience to get used to that. The field of vision changes dramatically when you turn the scope around because of the 70 degrees angle. But this is when you're looking from above down into the joint, and you see the ligamentum teres here, and you see here the inferior ligament. This is another view from the lateral portal. Here you see the acetabulum, and you see the labrum. Here you have pulled the scope a little bit back, so you have a kind of a mixed position. You can see both inside and outside, into the peripheral compartment, into the central compartment, which is very useful when you start out doing these procedures for orientation purposes. These are anatomic variations that you always will find when you're doing hip scopes. First of all, this is the acetabulum, the cartilage of the acetabulum. This is the labrum. It's normal that in several areas there is a cleft between. Sometimes it's even totally separated. And this should not be misinterpreted as a labral tear. It's the same, it's very analog to what you see in the shoulder, if some of you are shoulder surgeons, where you know that anterior and anterior superior, you can sometimes have a labrum that is not at all attached to the glenoid. So this is the same in the hip, both anteriorly and posteriorly actually. You can have this cleft, and it can be completely separated actually. This is then the stellate crease, which is the remnants of the fusion of the three nuclei in the embryonal and the childhood. And this is the physical scar, which is the same, which all has a close connection to the cotyloid fossa. So these are not cartilage damages, these are normal anatomical variations. Then when we move over to the peripheral compartment, there are several ways of doing that. You can do, as Vikas told us, to have a separate portal for it. Or, as when we operate in the supine position, we usually just pull the scope a little bit back so it's at the edge of the labrum, and we release traction, and we are inside the peripheral compartment. You can move in and out as you like. It's actually very easy. Sometimes it's necessary, it's narrow, and it's thick capsule. It's better to have a special portal, but normally it's not necessary. When you want to look around in the peripheral compartment, there is a good idea to do it in a very schematic way and do it the same way all the time. And as you see, this is the Dienst portal with the scope in the supero-anterior position. And this is the systematic way of examining the peripheral compartment as popularized by Mikkel Dienst. He goes stepwise through all the several points of interest in the peripheral compartment and visualize them one after the other. And I will just take you to this little round here. We start at the point A, which is the anteromedial part of the peripheral compartment. And this is what you then will see. You are now with the scope in this position, and you can then see here the neck of the femur and the femoral head. And this is the medial synovial fold, and this is the zona orbicularis. So what you're looking for is actually the medial synovial fold, which means that this is the limit, the border of the anterior part of the peripheral compartment. And this can also contain vessels, so you should normally don't do surgery on this. Then the next position is a little bit further up, more anteriorly, and there you see more the normal shape of the zona orbicularis here. Here is the capsule, anterior part. Here is again the femoral head, and up underneath here will be the labrum. Then we move on to the position C, which is distal in the peripheral compartment, where the intertrochanteric ridge and where the capsule attaches to the neck of the femur. This is what you here see is the capsular fold here and the intertrochanteric ridge. Then we move to the more cranial and medial part of the joint, where we also can see down to the joint surfaces with the labrum up here, with the recess, the perilabral recess, the femoral head, and here again the zona orbicularis and the neck of the femur. And this is then anteriorly in the peripheral compartment, and what we here see is the neck of the femur. We see the labrum, and we see the perilabral recess and the capsule. And now we have moved to the lateral part of the peripheral compartment. Here again, the neck of the femur, the labrum, and the perilabral recess. Here is the bony edge of the acetabulum, which can be felt by palpating this area. You can clearly feel the change from the bone to the soft tissue of the labrum. Then we have moved down to on the lateral side, and we can here see the lateral synovial fold, the neck of the femur, and the zona orbicularis again, which is the capsular structure. And here we have moved all the way to the back. So here is the head of the femur, here is the labrum, and this is the posterior recess, which is a very typical location for where loose bodies will collect. And this demonstrates that when you're in sometimes it's difficult to access the central compartment to start out. Then it's a very good idea to start out in the peripheral compartment. And then you can, under direct vision, you can put your wire under the labrum, between the head of the femur and the labrum, and you can gain access to the central compartment without doing any harm to the labrum. So this is a good idea if it's a tight hip. Like everything else in the world, the crucial factors for hip arthroscopy is visibility at working conditions. And this guy here, he has what every arthroscopist fears, a total red out. Everything where he looks is only red. Whereas this guy up here, he has a complete overview of the situation, can make good choices, and can move on, and can make sure that he wins the race. So that's crucial. Thank you.
Thank you very much, Tom.